click the record button and let's kick off this discussion. I am so psyched to have the three of you here today and share your resources and let our audience know you a little bit better. So I like to break these discussions into 3 rounds. Round 1 is let's get to know our care managers. Round 2 is let's just sort of have that open conversation on what they see going on in the market and what are some of the challenges that are going on with their clients and families. And then round 3, you in the audience are in the driver's seat here. So we love to get your questions and comments. So we hope you jump in and participate at any point in this discussion by typing in your questions and comments. So Margie, I'm going to start with you. I have known you for quite some time, but for those in the audience that don't know you, tell us a little bit about your background and what led you to care management and a little bit about your practice. And then we'll do Jen and Erin. Oh, and I might add before we jump in, I know I'm babbling. One of the cool things about this panel is they represent pretty much the entire Mid-Atlantic from the Delaware Valley down to the DC metro area, which is really nice that we don't have 3 care managers that are all serving the same 3 counties. So Margie, tell us a little bit about you and your practice.
Okay, thank you, Steve, and hello to everybody and to my colleagues on the panel today. And I will say that this whole program that you've been doing has been great, and I haven't been able to get to everything, but I'm so glad that you've been recording them because I really feel it's great. So, okay, let's see. I will say that as some other care managers had good relationships with their elders, their grandparents. I was very fortunate growing up. I had 3 grandparents that lived till 85, 86, and 99. And I always had great conversations with them. One of mine, the 91-year-old, she was very insight oriented, really, it was amazing. And so that's kind of where it started. I was a psychology major, undergraduate, but I always felt like I was going to be a social worker. And the school I went to didn't have an MSW or BSW program. I moved to DC, and my first job was with as a medical receptionist for 4 internists. I learned a lot about medical conditions. My second job was with Psychiatric Institute as an admissions intake counselor, and that's how I learned a lot about mental illness and a lot of diagnoses. The joke at the time as an admissions intake counselor is Psychiatric Institute at that time had an inpatient geriatric depression, alcohol, drug abuse program. And whenever we had an older person to be admitted to that program, they would look to me and they'd say, Margie, you take this person. So they always knew that I had this thing for older folks. Then I went to Catholic University, got my master's, MSW. And at that time, they actually had a certificate in gerontology, which I took that and I was able to get that. In fact, I don't even think they have that program anymore. So I was always kind of destined. My internship was with a nursing home as a social worker and the VA hospital, neurology. And then when I graduated, I worked for 4 different nursing homes. My last, so 14 years worth of nursing home social work job. My last job was at the Washington Home, which unfortunately is no longer there in DC, as director of social work with some staff. And I also worked on the dementia unit. So I've had a lot of years of experience with dementia care at all different levels. And when I had my first child is when I started to think about, private practice, give me a little more control over my schedule. And I bumped into Renee Delacroix, who's my partner, who was going to be on today. Unfortunately, she had to take someone to a doctor's appointment. And we bumped into each other. We met at a workshop about people thinking about getting into a private practice over 26 years ago. And we decided to join forces. She was working at Revit's house as a social worker. And I was in DC at the time, and I had worked at the Hebrew home, and I didn't know her. She was like the one person in this whole workshop that was aging related work. And I was like, how come I don't know you? And that's how we got together. And we purposely have stayed together, very small all these years. It's just worked for us. And, you know, I think some people come to us because they like the idea of a smaller boutique kind of a care management practice. We're both licensed clinical social workers and certified aging life care managers. And I think we do tend to get some cases where the family dynamic issues are pretty intense. And we do a fair amount of consultations with several adult children regarding their parents. So I'll stop there. Thank you.
I love it, Margie. And that one of the most interesting things for me in leading these discussions is seeing the wide variety of different practices and how they started and where they are. And I think today is no exception. So, so Jen, I'm going to go to you next and tell us a little bit about your background and how you got into aging life care, and then what your current practice is like.
So I'm the clinical team leader for Ferretto Eldercare Consulting in Lutherville, Maryland. We have 16 clinicians on our staff, and we all have kind of various backgrounds to bring to the table. We practice collaborative care management, meaning we have social workers, nurses, and gerontologists on our team, and we meet monthly to work together on especially the really trying cases that maybe need more time and more expertise. So we really we tag team a lot on our practice, and then we also have enough people that we can make sure our coverage is really nice for clients. My background, I started at College Park, University of Maryland College Park, and I was on the adult health and developmental program for 6 years as senior staff. At that time, I wasn't quite sure what I wanted to do with older people, but I knew that I liked them and I felt at home in their presence, and it just felt very natural to me to interact with them even more than people my own age. So at that time, I was surrounded by people that were, PhDs, master's degrees, professors, other professionals, elder law attorneys, social workers who also volunteered for this program on campus at Maryland. And they kind of pushed me towards getting a master's degree. And it's funny because no one in my family had ever gone to college. So getting a master's degree seemed like kind of out of reach for me, but they pushed and I listened. And luckily, I ended up at what used to be the College of Notre Dame of Maryland, which is a historic women's college in Baltimore, and started in their adulthood and aging master's degree program. And at that time, I was trying to figure out how I'm going to use my degree because I really wasn't sure yet. And I picked up a guide to retirement living at the grocery store, and I read all about care managers. And I thought, well, this is what I want to do. So that was 1998 or 1999. I got really stoked about care management, and I just sent my resume to every care manager in the Baltimore and DC area. I was lucky that someone scooped me up, even as green as I was, because I was enthusiastic and passionate. And so I trained the last year of graduate school. I was also, I was working full time and in graduate school full time and learning the ropes. Since then, I've worked in 4 states, and I've seen care management done very well across the board. But the Mid-Atlantic and the East Coast, boy, we really we have something special. And there's just a lot of knowledge and seasoned care managers that we can, tag team with or draw from. And so I worked for Mary Faith Ferretto. She was one of the first care managers in the Baltimore area. She formally started about 13 years ago. I've been with her for over 5. But we serve the Baltimore and surrounding regions, and we do have clients in Delaware, Southern Delaware particularly. And also we are one of the few care management groups that serve Southern Maryland. I'm originally from St. Mary's County, so I know that area very well, and we do have a couple of clients down that way. But we basically, perform very similar to what ALCA standards are, assessments, care plans, crisis intervention. We help families who are stuck, who really know they need help, but they're not sure who to call or who to hire or what to do, and kind of help them forecast what their needs might be too. So we're not looking at like immediate needs solely. We're looking at forecasting also, okay, this is what they need right now, but how about 3 months from now, 6 months from now, a year from now? So a lot of our clients come to us, preemptively, like looking for guidance for later. But then we have other clients too who are in the middle of a crisis and need immediate help, and we can jump in and help them too. So that's kind of our practice. Nice one of the older practices in Baltimore, but I know that my boss knows Margie and Erin well and has wonderful things to say about them, and she can't be here today, but she said, "Oh, wait till you see this panel. They're fantastic. They're
Well,
really
hey,
solid." So
I'm glad she invited you just for the purpose that I had no idea that we helped introduce you to this profession. So
yeah, and that
that's
was 21, 22 years ago.
yeah,
It
that's
was a
great.
great fit for me, and I think if more people knew about it, more people in grad school, undergrad, nurses, I think that this area really offers you a lot of flexibility as far as your clients and time, but also a lot of autonomy, which you're not going to get with a 9-to-5 job.
I love it.
So
Great. Well, thank you, Jen and Margie. And now that brings us to Erin Kershaw. And so Erin, let's hear your story, and then we'll jump into some topics, and feel free to throw out some questions and challenges at any point for those of you in the audience. But Erin, tell us a little bit about your background.
Well, thank you, Steve, for having me today. So nice to be here with Jen and Margie also. The company I work for is called Brandywine Eldercare Management. We started back in 2010. My business partner, Carla Payne, and I actually met when I was in graduate school. I started with a degree in nursing from University of Pennsylvania back in the 80s, then lived all over the country for 20 years. I did nursing work in and out of hospital settings. When my family moved back here in 2005, I was helping my parents support my grandmother. She was aging, had been a widow kind of young, and was doing really great, just a fantastic, autonomous, neat lady, and started to decline. And it was a struggle for my parents here to help her there. And at the time, we were not familiar with the field of aging life care manager, which back then was called geriatric care management. And I always said that sounded so terrible. Nobody likes to be geriatric. Nobody wants to be managed, even though it was the care that was being managed. So it's now aging life care management. But going through that process, watching the challenges, particularly the challenges from a distance, really not knowing who were the best people to support her there, who were the resources, who could attend the medical appointments, direct us to a good, assisted living community. We didn't know what was available there, and we didn't know there was anybody we could tap into. So after my family was settled back here in the area, I decided to go back to college and get my master's in long-term care administration, and to get a certification in gerontology from Westchester University. And that's where I met Carla Payne. She already had her master's in social work, and she was getting her certification in gerontology. And we were the two in that group who had personal family experiences and were drawn to this field. So we started the business back in 2010. In 2015, she relocated back to North Carolina, where she was from, with her family. And she now has a care management business there called Aging Care Matters. So if any of you are looking, aginglifecare.org, if you're in that area, you can find Carla there. I have been blessed since that time to bring on 4 other ladies here at Brandywine Eldercare Management And like many of the aging life care management practices, what's nice is that we have different backgrounds and experience, from social work to public health to psychology and my nursing. And I think that is an asset because we can't all know everything. So being able to work, as you said, Jen, collaboratively as a team has been really good for us. I feel good about it at the business. I think it benefits the clients. We're still small, so I like the idea of being somewhat of a concierge service. You know, we each have our own designated clients, but then we can refer to each other when there are questions, and there's always somebody available. I used to say during COVID, when we can get back out of town and go on vacations, then we know we have a good team who can cover us. So this has been an amazing thing. I still hear, as I'm sure we all do, people say, wow, I never heard of that field. I wish we'd known about you 3 years ago when we were helping our families. I think the interesting thing that we have been able to do here, and I'm sure other practices as well, is start a whole proactive planning segment of our business, where we're meeting with individuals or couples prior to a need. We're establishing that relationship, understanding what their wishes are, making sure they have the legal documents, the living wills in place, know sort of who's who in their life, you know, who has a key to your house, who is responsible for helping you down the road. And then when there are issues, hopefully before a crisis, we're already familiar and we can reach out to them. So thanks again, Steve, for having me on. I'm happy to be here.
This is great. Well, all right. So such an interesting, you know, Erin, there's these similarities between yours and Margie's story. We're coming together with a partner in this, you know, in a program. And then what I love is how Jen, how large is Ferretto Elder?
We have 16 clinicians now on our team.
Wow. So, you know, what a great panel, geographically separated, but also it just illustrates how different each individual practice, which is also, you know, as families are out there and as providers, as you're working with different families to refer to, understanding that, you know, there's just a wide difference, and it's great opportunities to make a match between the client. So what I'd like to do is dive into maybe some topics that you all would like our audience and people listening to this recording to know about. But I might sort of push you gently in one direction, because I think, Erin, you've already sort of opened up the door, and that is the topic of long distance caregiving and how valuable care managers can be. And I'm just kind of curious how you all work together with care managers that are in your region, but then, like in the case of your partner who's now in North Carolina, I mean, on a daily basis, I feel like I'm talking to people that are looking at options for, or helping mom look for options at staying where she currently is, or maybe moving to a place closer to the kids. If you guys would like to comment on how the network and how you all refer to each other, that would be really interesting.
Yeah, I think, and I'm sure the other ladies agree, being part of this national association, having a network of people. If I'm in the Philadelphia suburban area, so I may have an adult child here who has a loved one in an entirely different state, and that son or daughter is trying to determine, do we really want to move mom or dad close to us? Is it best to support them there? How do we do that? And then we can link up and tag team with providers in that area through our network, and have that, you know, care manager in that area conduct an assessment and make recommendations, either for living options or caregiver services there. And then we can discuss that with the family here.
And also, I must get maybe twice a week a referral request for an outside care manager in other parts of the country. And so I'm always getting on the website, trying to see if I recognize a name, if I know this person, a sense of their experience level. I'll email them ahead of time even. And, you know, I do refer a lot. We sometimes will have people from Florida who are thinking of relocating their parent here or moving them here. And a lot of times I'll even suggest, why don't we suggest, you know, get in touch with a care manager in Florida initially who could do an assessment, can give a little more information about your parent in terms of level of care, or especially when there's a concern about what if there's an emergency and they don't live right there. So at least they'll have somebody that they can, you know, can advocate for their parent, you know, even temporarily. So that's one way that I've used care managers outside. And I was telling Jen earlier that really interesting how a lot of us work together and do refer to each other. And we did have a mutual kind of case with Ferretto about a year ago, where a daughter called me and mother was living in the Baltimore area and they didn't know what to do because there were 3 adult daughters and they were trying to figure out either where to place mother. And so I referred them to Ferretto, and Jen happened to be the one to get involved, did a consultation with them. And then they decided to rotate at the different daughters' houses for a whole year. Ironically, I just got a call from that same daughter yesterday after a year saying, we talked with you and the other person, and I think we another consultation because now we have to figure out what else we're going to do with mom. So this was a great example of how we can work together, you know, as issues come up. And we cover Montgomery County and a little bit of Northwest DC, but mostly Montgomery County.
One of the ways that we've been really relying on colleagues across the country, sometimes across the world, is getting a professional assessment versus the self-assessment of the older person who isn't near family to really, you know, confirm that what the older person is saying is that their self-assessment is really, really reasonable or accurate. We have a lot of clients with kids all over the world, and they maybe talk on the phone once a week, they catch up, but the calls are usually very brief and they don't really get to dig into the meat and potatoes of what's going on with mom or dad, because mom or dad, you know, just hasn't gone there over the phone with them. So like I have a client now, his 2 sons, one's in Pakistan, one's in India, they're both in the military, and he's in St. Mary's County. And he's been telling them over the phone over the course of a year that he's fine, everything's good, you know, but they just sensed that he was, you know, cognitively declining, and that maybe he wasn't being, you know, as not honest, but he doesn't want to burden his sons. He doesn't want to tell his kids, you know, guys, you know, I lost your mom a year ago. I feel like I'm slipping a little bit. I'm not able to drive as well. He just can't go there with his boys. He doesn't want his boys to know those things necessarily about him or to discuss them with his sons because it's just awkward for him. So one of his sons got in touch with us. Because I'm from St. Mary's County, I have family down there. I was able to go down there one afternoon, do a full assessment. I was there, you know, 2.5 hours, looked at the home, assessed the client, assessed the cognition, and then was able to give an accurate report to the sons overseas. Now that was about, gosh, that was quite a bit ago. We've been working with this family for about 1.5 years, almost 2 years, but now it's time for dad to be placed. He simply isn't safe in the home anymore. There's stairs. He's had multiple falls, multiple hospitalizations. And now his POA son is back in Northern Virginia. So I'm tag teaming with a care manager out there so that I can, you know, hand her the baton and she can take it from there, because dad's going to now be in her jurisdiction as far as care management goes. So we can work with other care managers in any number of ways, but just having that accurate information and an objective opinion from another professional really helps us do our jobs better. Whether we're going to keep the case or pass it on to someone else and let them take the ball downfield is, that's, irrelevant. It's that we can get the information that we need at the time and best serve the client and make sure that we have a really accurate idea of the real issues in the pending looming crises that are going on. So
the great feedback there. And while you came in, those of you who are following chat, I really appreciate Hugh, who shared a situation. Now he's dealing with a Northern Virginia, a loved one in Northern Virginia, but I'd like to sort of read this because I'd be curious about any kind of feedback you might give Hugh and his situation. And this is the coolest thing about doing these live and interactive is like you get to sort of get some feedback from 3 care managers. But what Hugh says is, my mother is 102 and a half. Okay.
Good for her.
Yeah, lives with my brother and his wife in Woodbridge, Virginia. I'd appreciate any resources either of you are aware of in general geographic area of Woodbridge, Virginia. My brother and I can contact and maybe provide help with our mother. Someone who can just chat with her, and also home care support if necessary. And then later he says, my mother receives 12 hours of support from Prince William County, but yes, we could use home health care support. I did go on Alka, and Hugh, hopefully you saw, I provided a link of those care managers that pop up serving Woodbridge. So that might be a great resource, but just curious for you guys, maybe some comments on, clients that you've had in similar situation to Hugh and his family, where a family is, mom is living with the family and they're doing the best that they can. Any words of wisdom or ways that care managers help in these situations?
I'm sorry, go ahead, Margie.
You can go. It's okay.
I was just going to say, we all deal with scenarios like this. I have a 101-year-old client who's currently living with her son and daughter-in-law. And it's terrific that she can live there and have a good housing situation and the love and support of the family. But, they're busy. They have their own jobs and responsibilities. So what we as care managers can do is conduct that assessment and make recommendations. We vet caregiver agencies. We can arrange for licensed clinical social worker counseling and other services to support. And because we have no financial relationship with any vendor or senior living community we work with, it's always customized just to those scenarios that are the best options. So we can cull through all of that and then say, in your mom's case, here are the ones we think may be the best bet, and this is why. We can be as involved from that point as needed. We can be there for caregiver introductions. We can, help educate the family on what they can expect and what questions to ask.
One of the things that I've started to do a lot more these days is the resistance sometimes to having even people like us to come in to do an assessment. So what I say to the adult children is, don't use the word assessment. Let's just call it a consultation. And so, and usually for certain people living alone, and the funny thing is I have a new client, 101, who's living in his own home, and he doesn't want caregivers, even though right now he had his first thing in the hospital and rehab. But anyway, we'll see where that goes. But the bottom line is, I really feel that if the family can just say, Dad, you want to stay in this house. And sometimes we need to know what the resources are. So in the event you need some to take advantage of these things. So it doesn't have to be focused on now, even though the reality is it could be now. I often will say, don't use the word assessment, because it sounds kind of like, what is an assessment? They think of the doctor then. And it's just a little bit easier. And so I find I can get in the door a lot easier. And then I even say to them, I'm here for and do you mind if I ask you some questions, and that kind of thing. So that's one point there.
One way that we sometimes get our foot in the door with clients and most of them are not enthusiastic about having a stranger come in their house and tell them what they need. I wouldn't be either. And, you know, some of them maybe have been treated, you know, like children, or, you know, talked, you know, there's many things about aging that are difficult for people, but being treated like they don't know what they need or who should be providing the services must be just incredibly frustrating for an older person. So what we tell the family sometimes is introduce our help or our visit with the parent like it's for the kids, not for the parent that needs services. So we say, hey, you know, and even if we can call up the older person or make an initial contact and establish a rapport before we go out in person, that's helpful. But sometimes I'll say, you know, this isn't, you know, I understand that you're very independent and that you're very capable, but this is kind of a gift for your kids so that they don't worry so much, or that so that when you need help, we'll know who to call. It's just insurance like anything else, you know, good planning and looking at you steering your own ship. I mean, if they wait to get help, their options are limited and they might not have the capacity to make decisions. When they proactively make decisions, they stay in charge. They stay in control of ultimately their care, where, when, how, and how much.
Yeah, no, I love it. And folks, I mean, Hugh, thank you for sharing your challenge there. And for those providers in the audience, make sure that you put your information in there if you could be of help to Hugh. I think this is wonderful guidance. And I think, Margie, you brought up cost and I mean, cost from the perspective of how much resources are available for the family. But it always happens on this discussion, and we've got two questions asking about the cost of care management. Maybe you could talk, and you don't need to talk specifically, but how each of your practices charges, and it always comes up in terms of, is this too expensive for me? And I'm always interested in how care managers respond to solutions for somebody who might be on a budget and might feel that care management is cost prohibitive.
Well, you know, Renee and I have always enjoyed doing consultations all these years because we feel we give so much information to families. And actually in the last few years prior to the pandemic, we would actually get sometimes calls from couples who would say, I don't want to burden my children. We want one of you to come out and meet with us. And those are the kinds of calls I love because that's the proactive kind of approach. And I will say since the pandemic, not only I'm sure all my colleagues here have been getting amazing number of referrals right now, because I think all these adult children and families and seniors themselves, spouses, have seen major decline during this pandemic time and physical decline, cognitive. So I think a lot of us are busy right now, but on top of that, you know, in general, I just lost my train of thought. I was saying,
consult, 1 hour consults.
Oh yeah, right. Thanks. Right, so I'm also getting calls from couples who, as it was mentioned, I think earlier somewhere, younger people who are coming out and saying, you know, since this pandemic, we now know that we have to get our ducks in order and we're going to update our wills and can we have a consultation? And, you know, so we're definitely seeing a lot more of that as well. In terms of cost, I think there's a range and it really varies a lot around the country. I mean, I know like New York City probably is one of the more expensive care management rates, and the home care rates are even higher than here. So, you know, the range right now for what I would think is somewhere between 150 to maybe 175, 100, 200 an hour in this area. We do individual consults, we do the ongoing care management, and we do have a care management agreement if somebody wants ongoing. And then We offer a comprehensive package, which would include an initial consultation, a home visit, the probably getting HIPAA authorization to reach a doctor, get a little more information medical. We write up a report, approximately 3 pages, 3 to 5 pages sometimes. And that's for us is like a one package. But I will say in the last couple of years, we don't get as many people really wanting the written report. We're finding people, maybe because the need is so more immediate, we'll get more requests for, can you just give me a summary of the recommendations that you're making? So that's been kind of interesting for us. So we're very flexible. We don't have the kind of arrangement where if someone wants us to be a care manager, we don't say, yes, we have to visit your relative every week. We really do visualize it, and we just kind of decide what sounds like it makes sense. We propose that, and if the family agrees, that's the way it is. If we're helping with evaluations for placement, sometimes they do want to use us short term as part of the transition, which we feel, I'm sure all of us feel that it's valuable for care managers to help with the transition, which is a tough time for a lot of families and the seniors. So sometimes that becomes long term, sometimes short term. So we're very flexible in that regard.
Cool.
Yeah.
Any other thoughts on cost, Erin or Jen?
Sure, we do. We're also very flexible. We bill by the hour. We'll do as much or as little as our clients need. Some do want full, assessments and written care plans, somewhat more specific services. We have clients we see every week. We have clients we check in with quarterly. We have clients who are at times blessedly calm and stable, and then we come back in and have to do some more intensive work when the need, continues. I'm sure all of us have those initial phone calls with potential clients where we're really trying to gauge what is the need, what are you looking for, and then it's our responsibility to say, this is what we can do, and here's kind of an estimate of how much we think, how much of our time that may be. It may be more, it may be less. But if we talk to somebody who says, there's clearly a need, and they say, well, I might be able to afford an hour, then I know that's probably not the best use of your money. Let me give you some resources and direct you to options through the county or through the VA that might be a better, more comprehensive way of approaching. I don't want to turn away, an opportunity to help somebody, but I also want to make sure we're the good fit. But they don't have to, in our business, choose up any kind of particular preset package. And again, it varies client by client.
I think Erin and Margie both said the model is changing, and people, their expectations are a little more immediate. Maybe it's just the times that we're living in that people want, information, quick turnaround on recommendations and all of that. So we're doing a lot of that too. And I think more and more we're doing just one-time 1-hour consults with families, and those are affordable for most people. And if there are several kids that are involved, an older couple with several siblings, sometimes we'll suggest that they split that 1-hour cost and make it more affordable for them. And then too, they have ownership of it too. It doesn't just serve as paying for that 1 hour, but then they're also part of the process. And it helps maybe them feel a little more devoted to that process and to the ultimate outcomes. But we have people just call and say, you know what, we know that we need some help. Can we just come in and pick your brain for an hour? Because our doctor said we can't be home by ourselves anymore, and we don't know what we need. And part of the difference, and Erin touched on this before, and I think it's really a pivotal piece of what we do. We are not financially tied to any service providers, or we're not under some big umbrella that we only refer to under our umbrella. We refer to whomever we feel is the best fit for the client. So you're not just going to get, if someone comes in and wants to know about assisted living, Like there's assisted living that, group homes that you can get into with great care for $3,000 all the way up to the super fancy bells and whistles for 10, 11, 12,000 a month. So we can just help people become educated on what their choices are, narrow down the region they're looking at, the costs, and what amenities might best suit them and where their families are at. And just offer them a short list of what to look at. 9 times out of 10, we have people want to come back for more. So that's a lot, that's how we get a lot of our long-term clients now, is just they want a little taste, they want to see what you know, and they want some objective ideas, and then we kind of hand them the short list, and they can take it and go, or they can come back and talk about, then not just the primary issues, but then the secondary issues too, things that are on their mind that maybe need some professional support for as well.
No, that's great. That's great. I thank you for responding to that. And hopefully everybody has a little bit of a handle, but the recommendation is don't not look at a care manager, but call a few, find out, how they can work with you, which ones you're comfortable with. Tracy had a follow-up question on the costs. Are you aware of the new assisted living and memory care communities? Do you tour them to learn about their levels of care? And do you or your company earn a referral fee from these communities? And I think, Jen, you addressed that a little bit.
It's not allowed with our ethics. ALCA does not allow that. And we hear a lot of people try and kind of here and there, mostly new people who really are still getting to know how we work as care managers, but no referral fees, no kickbacks, no gifts. It's if there's exchanges of any kind, it's just not allowed. We have clients too try and, I've had a client, God bless him, he bought me a purse after I placed his wife, and it was beautiful. I said, this is so beautiful, and please tell my husband where to shop for my Christmas presents. but I can't take this, but thank you so much. So we really have to hold fast to that standard, so that people don't have bad experiences with ALCA members, so that we can level that high caliber of excellence and objectiveness for our clients.
And I think,
sorry, Steve, I was just gonna.
Oh, sorry. Yeah.
I was just going to add, we do visit, obviously, all of the new communities, find out who's there. We really like to know who's working. The new buildings are all, but who are the people who are there? Who's the admin staff? Who are in the individual units? So we can get a sense, because our clients are counting on that for that sort of inside information and perspective on what might be a good fit for them. And also, unlike some of the placement agents, we follow our clients after the move. So, we want it to go well afterwards. We can help manage the expectations, help with the communication, attend the care conferences, and all of that is done. We charge our clients for our time. So again, we don't have any financial relationship with anyone we recommend.
Yeah, and I just wanted to add that, we don't, I can't put on forgetting my.
Geez, Margie.
I don't have my second cup of coffee. That had to be it. No, I just want to say, no, the fact is we give out a lot of free information. As you said, we're not affiliated, and I think we all feel good about the fact that we're not affiliated with the resources that we recommend. So a lot of times we do give out names of elder lawyers, home care agencies, even if we're not involved, and they say, we just need a couple names, blah, blah, blah. And, we try to get a feel for where they live, a sense of their parent situation. And we don't charge. I mean, we all do an initial, what we call intake, just to get an idea whether we feel that we can assist them. And if not, we refer them out, or again, if it's just a resource kind of thing. So I just wanted to make sure that people are aware of that.
Really good question from Ruthie here that I'd be curious on your feedback on is, I'm curious from the care manager's perspective, what the current climate is for families' comfort and confidence level with placing loved ones in communities. it felt it was taking quite a bit of time with COVID for families to feel better about moving forward with placement. But fortunately, now that things have started to pick up a bit, what's your sense of this? Any perspective on that with your current group of clients?
I think there's some ambivalence right now. I mean, I definitely had some clients during the pandemic who did place their relatives, they had to, in some of the smaller group homes. And, you know, we always recommend, you know, I think the reason why they went to some of them is because they had the opportunity to visit a lot easier. I'm finding more people, because of their situations, are starting to explore more in general of all the different assisted livings. And in Montgomery County, we have like 5 new places that are going up. I mean, I haven't had time to get there for the tours yet. But, you know, I think it's coming back again. But I think part of the problem is there's a lot of new places. And so I know there's vacancies in general related to the pandemic. And I know some of the larger assisted living communities have been having more tours and bringing in more people, at least from my experience.
I wanted to add, Margie, just to kind of piggyback on what you said, some of the larger places that used to be full, or the better facilities, or the places that have openings for the first time because of COVID. So in my opinion, I feel like my clients, our clients, have more options than they might have before COVID, because some of these nicer places are willing to negotiate. They're willing to give in on a few things, like we're able to get maybe community fee waived, or a discount on their monthly rent, or free month or 2 up front, so that they can get their finances in order. I mean, I feel like this is a really good time for people to consider placement. And when things are fully opened up again, you know, there might not be so many openings, there might not be so many opportunities, especially, I mean, most of our clients are kind of fall between having resources and not having any resources. We do a ton of Medicaid, the 3871B Medicaid medical assessments for families who are, you know, simply don't have resources to pay for long-term care for their loved ones. And we're seeing like some of those, even the skilled care facilities, particularly the dementia units, the secure dementia units that didn't have any openings, do now. And some of the better nursing homes. An example is the VA home in Charlotte Hall. I've probably placed 2 people there in the past 6 months. They had a 1.5 year wait list before COVID. And now they don't. They have lots of openings. And if you're a vet or a spouse of a vet, I mean, this is a good thing. You can age in place there. It's just, you know, there's an upside to everything. I think COVID has just kind of knocked the wind out of most of us, and we're just looking for relief. But there are some benefits to the current climate in the housing, and I think our clients are benefiting from that.
Another good question came in here, and I love this one. It's from Irene, and she says, "My husband and I live independently in a life plan community." Irene and your husband, great move. You know, whenever I interview people that make that move, it's they always are happy about it. And how can a care manager help us move to the next step? So number one, Irene, I wish everybody had the foresight and planning that you and your husband have. Unfortunately, we deal with a lot of crisis situations, but have you guys worked with some clients that are as proactive as Irene and her husband, being in a life plan community and sort of thinking about, okay, how could a care manager help us a little bit more?
Yes, and in fact, my own parents live in independent living, in a home in independent living in a life plan community. My recommendation to everybody out there is consider moving when you're young enough that you can take advantage of all the wonderful things that are available there. I think sadly, some people wait too long and then they miss out on some of the benefits of those options. But we can work with clients at any level, completely independent, assisted living. Here in Pennsylvania, we also have personal care, memory care, and skilled. So in a scenario like you're talking about, My recommendation is establishing a relationship with an aging life care manager now to understand the same things as you may have living in your home in your prior community. What are your goals? What are your desires? Who are the people in play? How can we, in our professional role, help support you? Even though you're in a life plan community, your goal may be to stay in the independent living place where you are right now. So how can we help support that? And then how can we negotiate with the staff on your behalf if at some time there is a need to move to a higher level of care there?
One of the biggest questions that I'm finding in the last year and a half, 2 years, so many more people have long-term care policies. And I'll always ask that as part of the assessment when I first meet them, and they'll say, yes, we do. And then I'll say, you probably have no idea what your benefits are. This is the time to start learning more about your policy, because if they signed on X amount of years ago, they're not thinking about it. And some people forget they even had a long-term care policy, even though they pay their premiums. If they do an annual, then they forget about it. So even in a setting like that, they may or not have looked into it, but so many people, from my experience with the CCRC campus-like services, when they're in independent living, they rarely move to assisted living, from my experience. You can build in home care into independent living. They prefer to stay in that lovely apartment that they selected. The assisted living rooms are usually, apartments are going to be a little smaller anyway. And usually you can stay in independent living unless there's a wandering issue or medically something really does happen that one of the two really requires that much more medical attention. So, I mean, to me, it's just really important to know what the resources will be in the event they wanted to stay in their independent living section ongoing. So that's where I would answer that.
Great. Well, I'm looking at the clock. This always happens with the aging life care managers. We got a handful of questions that I got to get through here. Are you guys okay staying on for a little bit longer? And we'll try to get through these. And then for those of you who have to jump off, we recorded this so you can check out the recording. Let's see, Ellen Pincus with Cavalier Home Care. She's asking which care manager covers Virginia. I guess, Margie, you're probably the closest, but do you
We don't do anything in Virginia. We refer to care managers in Virginia.
Okay, great. And then let's see, I'm going to give a shout out for David at Personal Living Alert. He says, I love care managers, but that's also a good opportunity for me to sort of say, like, things like fall detection, technology, things like that. Do you help people navigate whether and what they might purchase for their mom and dad and sort of help them get acclimated to things like that?
Definitely, that's part of what we do with our assessment, home, modifications if necessary, accessibility options. And I have had clients work with David at Personal Living Alert. He's one of the corporate sponsors for ALCA. And I know he's been a great resource for us. And that's another thing on the aginglifecare.org. You can see who the partner are there as well and look that up. But that's been a great asset for us, I think, as ALCA members.
Great.
Most people do want to retire in their own home. Keeping people home with technology is something that we have now that we didn't have 20 years ago when I started. And people have a lot more options and a lot more supports through these technology providers to stay in their home. It's just, we kind of help, spread that out and let people know, okay, you know what, if you are at risk for fall, we see that when we're in their home, and then we can tell them, you know what, there's a lot of new stuff out. Let me tell you about this, and let me tell you about that. And then we can kind of point them in the right direction, but then they ultimately decide, do I want a pendant? Do I want a watch? Do I need it to work outside of the home? Do I need it to have GPS? I mean, there's so many different options now for folks, and it allows them to live and retire the way that they want to. And as care managers, we do want to push for autonomy and independence, and we advocate for that first and foremost. But tapping these technology providers, these, whether it's a pendant or a watch or GPS, whatever, what have you, is a great way for us to advocate for our clients and let them hold the reins a little longer, and live the way that they want to.
And it's
And,
also an education process, I find, because we can push and recommend to have one of the pendants or GPS or something, and then eventually they say, okay, or sometimes I'll say, well, if it's their birthday or if it's Father's Day, maybe as a Father's Day gift, the family could purchase, one of the emergency response kinds of things as a gift. But what I do is when I visit, I'll say, where's your pendant? Where are you keeping it? How are you using it? And I'm finding more people less resistant to these days. I'm really finding the technology is starting to really, well, of course, all of us became more savvy during this whole time with the Zoom and all the different platforms. But it's great that there's more and more kinds of technology.
Jen, you referenced, I believe somebody says, what is the 387 1B Medicaid assessment?
387-1B. So when people have basically depleted the resource, whether it's they never had resources to begin with, or they've spent so much on care that they simply are tapped out and they have less than $2,500 or less in assets. And an elder law attorney would, that's their area of expertise. We just handle the assessment on the Medicaid portion for the medical part. And this assessment, it's different in every state. I know Virginia has a different one than Maryland does. Generally, what they're looking at is what kind of support, hands-on physical support, does this person need, and why should the state and federal government combine forces to pay for the care. So you have to qualify fiscally first, and that that if you don't get that right, it's a no-go, and you can be penalized, and you can, but then once you've come to a point where you're at that threshold for assets, and it's always better to do it ahead of time. We recommend people to call a care manager to assist with this process well before your assets are depleted. But we basically come on site and we do a physical evaluation. We review all the chart wherever they are, medical records, health history, medications, and fill out the forms, which makes up the 3871B. And it's, basically what kind of help with ADLs, are there medical needs that can't be met with like assisted living or home care. And then too, there's a cognitive portion to it. We're finding more and more that people are needing to be placed due to cognitive deficit. Maybe they are physically somewhat capable of performing their ADLs, but the problem is that they're not able to remember to do these things, and they need extensive cueing or someone to do these for them because of cognitive deficit. So they basically would neglect themselves. They just fall apart if left to kind of fend for themselves. So we perform these 3871Bs, and then we submit them to Telegen, who manages the Medicaid applications for the state of Maryland, at least in Baltimore. And we wait to get approval or a denial. And then we partner with the family to do the placement piece, which is, the Medicaid basically gives you a window. If you get approved, it used to be 30 days. I know they've been a lot more flexible since COVID. So we do like an advisory 3871B, and then we help, if the family chooses, help them with choosing a skilled care facility to ultimately place their loved one.
But just to clarify that the 3871B is for long-term care nursing home placement.
Yes.
It does not
Yes.
cover assisted
Right.
living.
Yes.
And I don't know about Pennsylvania.
No, it does not cover assisted living in Pennsylvania either.
No, we have waivers, but quite honestly, in Maryland, the wait is up to 8 years right now for assisted living type of supports in the home. From our perspective, that's just simply not an option for most people. Our staff, actually, Mary Faith, my boss, and myself, we've been to Annapolis the last 2 sessions, and I think it was 2019 and 2018. They haven't met in person to discuss these since then, but trying to help pass legislation to front load these waiver programs. Maryland's are simply just in disarray. I know Virginia is doing a lot better with their waivers, and there isn't a wait, but that's basically what you can get as funding for care beyond or before skilled care. So
Yeah, that's great. And then is it a question follow up on that, which I think you just answered, is the assessment that a life care does for that, is that paid for by Medicaid? It's probably not.
no,
Okay.
it's not. And you know, for some of these folks that are already in skilled care, maybe they're in rehab after a hospitalization, these rehab facilities can do these forms for you as well. Usually the nurse or the social worker, they have someone on staff there that can do these 3871Bs. So there are other options besides a care manager to do these. We just so happen to do a lot of these and do them well. And we get a lot, we have a really good track record with approvals because we can provide that supporting documentation and maybe dig a little deeper because we have the time to devote, a chunk of time to these applications versus just trying to fill them out quickly and submit them as fast as possible. So.
All right, I got one last question, and this is a great way to close it out. And let's see. Well, wait, let me look at this one real quick. Okay, so one just popped in. Elderly person poaching, holding food in cheeks, not swallowing. The nurse says they have to be reminded how to swallow food. This happened with a family member. Is this a sign of cognitive decline, or what should a family do? That could actually be like something that Susan Rannick.
Speech therapist.
Yeah.
Have a speech therapist come. They can do their thorough assessment. They can make diet recommendations and go through their protocol to make some recommendations. That's another thing that we do. We're not speech therapists or physical therapists, but we can connect our clients with those services as well.
And but so I'll finish on our last question because I'm kind of curious about this, is where do most of your clients come from? Who are some of the professions or people that refer to you?
That's so funny. That's, I think, is the number one question that Renee and I have gotten over these years. It's so interesting. Well, for us, a lot of previous clients, and in fact, during this time now, we're noticing that we're also getting previous clients really coming back to us. Sometimes it's 7 years later, different relatives, 5 years. We also get some referrals from doctors, other social workers, other colleagues, elder lawyers, really the whole gamut, to be honest. Some of the home care agencies occasionally, sometimes the marketing people from assisted living communities, and occasionally nursing home social workers. And the website, we get a fair amount on our website, and sometimes it does come through ALCA, where people have heard about the Aging Life Care organization website. Sometimes we also get from there. And a lot of people Google. I'm always amazed when people, we always ask, oh, how did you hear of us? And sometimes people will say, oh, I just Googled counseling or geriatric or something, and that's how they find us, which is always amazing to me when people just automatically schedule a consult or a assessment. And I mean, I think in 26 years, I had maybe 4 people who said, can I have some references? And I always think to myself, if I was looking for my own parents, I think I would ask for references. But it's amazing to me. I don't know about you ladies, what you've, come across on that regard.
I would say all of the same. It's so nice when a former client contacts us and said, I've given your name to my neighbor, my cousin, my aunt, and the same resources that Margie said, home care companies, other professionals, money managers, senior move managers, on occasion, hospice companies. If one spouse has passed away and then the other's going to need some assistance, we can get some referrals from them. Medical practitioners, elder law attorneys, and like.
we're having, like, since ALCA's really exploded too, we have we've had articles written. I've written a couple, got published in a healthcare news journal, and then like a business journal too. We have a lot of us have the opportunity or been asked to kind of talk about care management, just like this forum that you have here, Steve, but on kind of a national platform to give examples of case studies that we've worked on. I think people really connect with stories. And sometimes just us, having an opportunity to write about client experiences or telling about how we were able to help a family that was in a situation, whether it's in a journal, in a newspaper, online magazines. With technology, I mean, people have access to information that they simply didn't have before. So we've got, word of mouth. I think that's, like Margie and Erin, word of mouth is our best source of new clients. But there's a lot of ALCA members that are very active in legislature at the state level and the federal level, but also prolific writers and people that are out there, kind of just tooting our horn, telling people about what we do and letting them know that we're out there and we're basically professional advocates who are looking to help people optimally age, whatever their situation fiscally. We can offer them all kinds of support, whether it's hourly or ongoing or in crisis mode. It's exploding. I think technology and the internet really has changed the game for what we do. But it is still word of mouth. It's, small potatoes. That's how we.
Great. Holy cow. We're at 1:15. And remember, before this started, I was sort of like, okay, I'm not going to let it go past 1:15. So the last thing I'm going to promise, this is what I'm closing on, is what is ALCA and what does it mean? This is just a reminder for all of us not to use acronyms. It's
Right.
Life Care Association. It's ALCA. Yeah, and just another great reminder. Thanks for answering that question. And let's see. So this now time is the season of life that we now all find ourselves in. Thank you so much. Great. One of our audience members said that, and I agree. Thank you for taking the time to share your profession with us today. And I'll make sure to distribute the recording and all the chat and the contact information to everybody.
Thanks so much, Steve.
Thanks for having us, and thanks for everybody for listening too.
Yes.
They're busy too. We know that, and thanks for just listening.
You bet. Talk to you soon. Okay, bye.